Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. This is a part of a series of what we call as a clinical side. We have finished with elementary system examination. Now we have started with respiratory system. First, we have done little regarding the introduction and general examination in respiratory system. Now we are starting with the other second part, that is inspection in respiratory system. Inspection in respiratory system as well as cardiovascular system is nearly same. There's a minor difference. Only in cardiovascular system we look in detail on a precordial region regarding the apical impulse, pulsation, deformities, etc. Here we concentrate on entire chest. So there's a minor difference between the two. So we'll be dealing with that particular part. I feel this lecture will be very useful for fourth year student in your oral exams, as well as some portion will be also useful in your theory. If you like this lecture, please press button like and subscribe. And also you can press bell icon so that you can get information when I upload a second lecture. If you like this lecture, you can share with your friends also. So inspection is just observation. You are not supposed to use your palm, and you are not supposed to auscultate also. So that is what we call as inspection. During inspection, you are looking at lot of things. You are looking right from the neck region till xiphisternum, almost up to umbilicus. You examine the anterior surface, you examine the axillary area, and you also examine the posterior surface of the chest. While inspecting the posterior surface, you usually ask the person to sit. While examining the anterior surface, person by and large is always in a supine posture. So whenever you want to do inspection, inspection is done by standing on the right side. What we say that you stand on the right side and erect, and you observe the neck portion, you observe the entire chest, what we call as the anterior surface. Also you can do an examination by standing at the foot end and compare right with left, which is very important to find out the difference between the two. Also, if you want to find out the shape of the chest, whether there is any bulging, retraction, etc., tangential examination. So you bend down, sit down, and look tangentially to the curvature of the thorax. This is what is included in inspection. While examining the axillary area, you will have to ask the person to elevate the shoulder and then examine by standing on the right side and by standing on the left side, or by bending forward. You can compare right with left axilla. So now we are starting with what we call as inspection. So during inspection, examiner has to stand on the right side of the patient. Like abdominal examination, we have already told you that the room should be fully illuminated. Good number of time the person examines the patient, allowing the patient to sit upright on an examination table, and you examine anterior, axillary as well as posterior. But the best way of examining is in a supine posture. So ask the person to move their arm forward to examine the posterior surface when you are asking the person to sit, and when you ask the person to flex the arm at shoulder as much as possible, you are separating the scapula so that you can see the interscapular region much better. All clothes from the chest should be removed right up to umbilicus. And in case of a female, you can maintain the dignity by partially covering whenever you require to examine the chest. So while examining the chest, you can remove the clothes, but as soon as the examination is over, you should cover the chest. What we do during inspection is we observe from above downwards, that is from head down up to umbilicus. You examine the front part we call as the anterior surface of the chest. You examine the axillary area, or what we call the lateral area, by examining, by standing on the right side. You can see very clearly the right side lateral part of the chest, and bending forward you try to examine the left side of the chest. And while doing this, you can ask the person to abduct at the shoulder joint and then examine. While asking a person to sit upright, best examination of posterior chest wall will be best examined, and while examining the posterior wall, you ask the person to flex at shoulder as much as possible so that the two scapula are separated maximum. Hence, the interscapular region is maximally seen very nicely. As well as when you ask the person to abduct and elevate the arm behind the neck, you will be able to see the axilla on both the sides very clearly in a sitting posture. So, whenever you want to examine the anterior surface of the chest, best is in supine posture. Ask the patient to lower his gown up to umbilicus. You can examine by standing on the right side, and also don't forget to examine by standing at the foot end of the patient, so that you can compare the right side and left side, the curvature, movements, expansion, the shape, retraction, etc. So when you do inspection, you look at good number of things like shape, symmetry, respiratory movement, accessory muscle of respiration, retraction, and you can examine even the epigastric pulsation, which can be because of right ventricle or because of aorta or because of liver. So there are a lot of things which you examine, and if there is any swelling, you can look for all the detail in swelling, that is site, size, shape, surface, color, pulsation, impulsion cuffing, etc. If there is any scar, regarding scar you will be examining any skin eruption, any dilated veins, any pulsation, all those you examine and you mention in your paper. But when you go systematically, we'll be mentioning those particular and we'll go one by one. While examining the posterior surface of the chest wall, always you ask the person to sit up, sit upright, and stand on the back of the patient in the center. And now compare the right with left. And while examining the posterior wall of the chest, always ask the person to flex maximum at shoulder, so you separate the scapula as much as possible. Here you can examine the supraclavicular region, interscapular region, and infrascapular region. And you compare right with left. You can look at the cervical, thoracic, and lumbar spine, any deformity. You can look at the costovertebral junction, renal angle. On palpation and percussion, you can look for costovertebral tenderness. If there is any scar on the posterior side, you can look at the scar and detail regarding the scar, any pulsation, any dilated veins, etc. Now when you examine, we always go from top to bottom. That is, you examine supraclavicular region, infraclavicular region anteriorly, mammary region, inframammary, and then you go to the axillary region. In axillary fossa, infraaxillary region, posteriorly suprascapular, interscapular and infrascapular. So these three are posterior examination. These two are lateral examination, and this is anterior examination. So you follow that particular pattern, the chances of missing something will be very, very less. We have also mentioned that when you examine or when you do inspection of anterior surface of the chest, stand on the right side, stand at the foot end, and while standing on the right or a foot end, in erect posture, in little bending forward, and also sitting down and looking tangential. These are the three positions in which you can examine the chest by standing on the right or at the foot end, or you can examine by asking the person to sit upright and stand on the back and examine the posterior surface of the chest. While examining the posterior surface of the chest, you don't have to look tangentially. While examining the posterior surface, you are standing on the posterior side of the chest, means you are standing on the posterior to the person, on the back of the person, and you are looking at the spine, you are looking at the ribs, you are looking at the scapula, and you are looking at suprascapular, interscapular and infrascapular region. And you are comparing right with left. At the same time, when the person is in a upright position, axillary area will be best examined by standing on the right and by standing on the left side. And you can examine the highermost part of the axillary region and infraaxillary region and compare right with left. Now what you do in inspection, we look at all these things. We are mentioning and then we'll be going by one. Shape of the chest and shape of the precordium. Precordium is paid more attention when you are looking at the cardiovascular system. Position of trachea, position of apical impulse, respiratory movement, dilated veins, scar, any swelling, pigmentation, any smell or odor. And when you stand on the back, look for the spine, any pulsation, any deformities, and also you should mention in brief regarding jugular venous pressure and pulse and any accessory muscle of respiration working, or we call prominent. So these are all the things you look for. All these things should be mentioned in your oral exams. We'll be taking one by one. So first is the shape of the chest. Shape of the chest will depend upon the bony cage. And bony cage contains sternum, ribs and spine. So we look at all the three structures. As far as spine is concerned, it is based only in sitting posture, that is sitting upright. While in a supine posture, you can examine the sternum and you can examine the ribs. If you want to identify the exact shape of the chest, best is by standing at the foot end and compare right with left. You will be able to pick up a peculiar changes like barrel shaped chest, flat chest. In a barrel shaped chest, the AP diameter is almost equal to transverse diameter. You will see a bilateral symmetrical bulging of the chest wall. While in a flat chest, AP diameter will be markedly less or less than 50% of transverse diameter. and by standing at the foot end you will be able to compare any retraction or any bulging which is localized or whether it is generalized and bilateral symmetrical. So it becomes utmost important to examine this particular portion, that is regarding a bony cage, particularly the shape in a three-dimension picture, that whether it is a barrel shape or it is a flat chest or any other peculiarities, whether there is a localized retraction or there is a localized bulging or there is a generalized bulging. All this you will be able to identify if you stand at the foot end and compare right with left. And when you are standing at the foot end, you can stand erect or you can bend down little bit and look little tangential. Also, it can be benefited by standing on the right and examining the chest in erect, little bending forward and sitting down and looking tangential. So all this should be combined, and then only you should mention regarding whether the shape of the chest is barrel shape or flat chest, there is localized retraction or generalized retraction, there is localized bulging, etc. As far as the sternal deformity is concerned, that is called as, if there is external bulging of a sternum, it is called pectus excavatum. Sorry, internal. It is called excavatum, and when it is bulged out, it is called pectus carinatum. Ribs can have a congenital deformity like fused ribs. Sometimes it is absent, or post-surgical. Nowadays, because of a approach to the mediastinal structure or to the thoracic cavity, it is called minimal invasive surgery. Very rarely they remove the ribs, but in older times, while doing a thoracotomy or while doing a major surgery on lungs or while doing a surgery on heart, we what was called as open heart surgery, good number of time to have a good intercostal space for surgery, the rib was removed. So you might have one of the rib being removed if he is operated long back, say about 15-20 years back. Yes, you can have a chest deformity secondary because of the rib deformities, which can be secondary due to fractures or maybe flail chest. Flail chest means if rib is broken in 2 or 3 pieces, a portion of broken rib will move in opposite direction during inspiration. Normally during inspiration the chest expands, but in a case of a flail chest, the broken part of the chest will move inside, and during expiration it will move in the opposite direction, that it will move out. This will reduce the lung compliance, expansion of the lung. Hence, detection of a flail chest following a chest injury is very important, because it should be treated as early as possible. You can have a localized area of rib junction with a sternum, we call it a costochondral junction, which is made up of a cartilage which can get inflamed because of costochondritis. Or also you can have a bulging at the costochondral junction because of rickets or because of scurvy, and you can get a deformity at costochondral junction. We'll be discussing separately. If you look at the spine, you can have a deformity which is a lateral curvature, we call scoliosis. You got an anterior-posterior curvature deformity, we call kyphosis or gibbous. Kyphosis is a smooth curvature, anterior-posterior, bending forward. And in a case of a gibbous, it is a sharp angular deformity. Because of scoliosis, kyphosis or gibbous, there will be deformity of spine, and it will also have a deformity as far as the shape of the chest is concerned. And secondary to that chest deformity, you can have a lot of problem as far as the respiratory system is concerned, that is the expansion of the lung. And person can also have a restrictive lung disease because of extra pulmonary causes. With combined deformity like scoliosis and kyphosis together also, you can have a deformity of chest. Very rarely because of lumbar lordosis. to get a chest deformity is absolutely rare. Secondary to lung pathology, intercostal space can be bulged out or there can be retraction. At this stage, I would like to mention if there is any pressure in the thoracic cage increases, we call intrathoracic pressure, either because of pleural pathology or because of lung pathology. Say secondary to lung pathology like tumor, emphysema, intercostal space will be pulled or bulged out. And intercostal space will be retracted in case of collapse, fibrosis and thickened pleura. So retraction will be very commonly because of fibrosis, collapse or thickened pleura in the lung, and bulging will be very frequently because of tumor or say distension or expansion of the lung, secondary due to emphysema. While pleural cavity pathophysiology which can produce retraction will be thickened pleura or pleural fibrosis, while bulging will be because of massive pleural effusion, empyema, mesothelioma, which is a malignant tumor of pleural cavity. You also look at the costal angle, which is formed by the lower rib surface, or we call lower costal margin. So you look at the jiffy sternum and look at the costal angle. Usually it is acute. If person has got bilateral lung expansion in case of emphysema, the angle will become obtuse. So it is one of the important finding in case of emphysema. You can have some of the congenital deformities, or that is we have already mentioned deformities may be because of ribs or maybe because of spine or maybe because of sternum. So secondary to that congenital deformity, either because of sternum, ribs or spine, you can have a deformity or shape changes in the chest. So you will have a shape of the chest may be abnormal because of sternum, ribs or spine. Secondary to lung, I have already mentioned. Secondary to lung, unilateral pathology or bilateral pathology, or pathology because of lung, you can have a bulging in the intercostal space or retraction in the intercostal space. And also you can have a unilateral deformity or bilateral deformity. This is very, very common with fibrosis, collapse and thickened pleura. And as far as the expansion is concerned, in case of emphysema, tension pneumothorax. So I've forgotten to mention regarding a tension pneumothorax as far as a intercostal bulging is concerned, sorry, and that will be because of pleural pathology. So I have mentioned separately in a pleural pathology that there will be bulging because of the massive pleural effusion, empyema and mesothelioma, and we should not forget tension pneumothorax. And retraction will be very frequently because of fibrosis or thickened pleura. Heart will produce deformity if it is in an early stage because of congenital cyanotic or congenital acyanotic heart disease, usually in a newborn or in an early age group. It can produce deformity, but once the ribs gets calcified, then the deformity is less likely. Then very, very rarely because of massive pericardial effusion, you can have a mild deformity of precordium rather than entire chest. Aorta, because of aortic aneurysm, can produce deformity because of constant pulsation, and then later on you can have even a swelling which will be pulsatile swelling, and particularly if there is an aneurysm of ascending aorta or arch of aorta. Now we'll be showing you some of the slides regarding deformities. So if you get an AP diameter is equal to transverse diameter, if AP diameter becomes equal to transverse diameter, it will be what we call as a barrel shaped chest. But if the AP diameter becomes tremendously less, or sometimes we say that it is less than 50%, we call that as a flat chest. Flat chest, classical in case of India. It is very commonly seen in tuberculosis, we call phthisis or flat chest. Also, don't forget, you can come across flat chest in case of Marfan syndrome. In oral exam, they can ask you. That will be very common in case of a Marfan syndrome. Also, you can have a person who is severely emaciated like HIV, tuberculosis, malignancy, etc. So, tuberculosis comes topmost on the list as far as a flat chest is concerned. If you've got a bilateral fibrosis, then you can have a flat chest. But if it is unilateral, you will have an asymmetrical retraction of one side of the chest rather than flat chest bilateral. If the AP diameter becomes equal to transverse diameter, we call it a barrel shaped chest. Classical example of that is COPD, chronic obstructive pulmonary disease, or better example will be emphysema. Now you can have one peculiar type of deformity we call as a pectus carinatum, that is bulging of a sternum. It is also called as a pigeon chest. Very frequently it is a congenital deformity, and good number of time you can come across in case of a ricket. Occasionally in case of a Marfan syndrome, and occasionally in case of a asthma right since childhood. In that case, you can have sometime little bulging of the sternum, we call as a pectus carinatum, or we call pigeon chest. But classical example is a congenital and in case of a ricket. This is classical. You can see that this is barrel shaped chest. AP diameter is almost equal to transverse diameter, and that is very classical seen in case of an emphysema. So if we see this type of a chest, AP diameter is almost equal to transverse diameter, it is called barrel shaped chest. Classical. And you can see here there is a sternal deformity. This is pectus carinatum or pigeon chest. We'll show you other also, that is pectus excavatum, etc. as we go through. Along with barrel shaped chest, very frequently you will have a kyphosis. You can see the spine is curved backward. So this is a smooth kyphosis. So along with barrel shaped chest, you can get kyphosis. If you have got a lateral curvature of the spine being deformed, we call scoliosis. So in a barrel shaped chest, you can have two or three things together. If we describe, AP diameter is almost equal to transverse diameter. Ribs are horizontal. Intercostal space is widened. Costal angle is obtuse. There is a smooth curvature we call as a kyphosis. May sometime have even scoliosis. And along with that, you can have a sternal deformity in the form of a pectus carinatum. These are all things together may be seen in a person with a barrel shaped chest, we call as in case of emphysema. And even intercostal space will be full. So these are all together what you can get in a case of a emphysema. We have already mentioned pigeon chest or pectus carinatum. It can be congenital or in case of Marfan syndrome, very frequently in children because of ricket, and also in case of a childhood asthma. So pectus carinatum, very clear. When it is inward curvature, then it is called excavatum. Again, it can be congenital deformity. And pectus carinatum, this is pectus carinatum with prominent Harrison sulcus. You can see this. This will be characteristic in case of ricket. While inward is very frequently because of congenital deformities. You can see clearly, this is pectus carinatum. This is excavatum. This is again excavatum. Inward, inside. So this is excavatum. or it is also called as a cobbler chest or funnel chest. So in that, the sternum is curved inside, and if you look here, if there is, I'll show you that. Yes, here you can see that sternum has bulged out. That is carinatum or pigeon chest, and this is curvature inward, that is excavatum, funnel chest or cobbler chest. That you can again have in a case of a Marfan syndrome and by and large congenital. Then regarding a Harrison sulcus, we have already mentioned this will be classical in case of a ricket. You will have a groove along the attachment of diaphragm. That is called Harrison sulcus. And this is possible only if the person develops ricket in a very early childhood. So that will be very peculiar, Harrison sulcus. When you get a swelling all along all costochondral junction, it is in a scorbutic, it is called rosary, scorbutic rosary because of vitamin C deficiency, in scurvy, and ricketic rosary in case of ricket. In scorbutic rosary, it is a sharp angulation, while in case of ricketic rosary, it is a smooth angulation. Along with that, in a ricketic rosary, you will have a sternal deformity and you can have a Harrison sulcus. So in a ricket, you will have a Harrison sulcus, you will have a pectus excavatum or pectus carinatum, and you will have a ricketic rosary. As well as far as skull is concerned, you will have a frontal bossing and you will have a pot belly stomach. Means you will have a peculiar shape of the stomach. These are together very frequently asked in your oral. So do remember these things. So this is normal. You can see here the AP diameter is increased, barrel shaped chest, a smooth kyphosis, sternum inward excavatum, sternum outside carinatum. During inspiration, if the portion of the chest wall moves outside and during expiration it moves inside, it is flail chest. Do remember, this is very frequently asked in your oral. That is, we call it a paradoxical chest movement. So when a person takes deep inspiration, the portion of the chest wall, if it moves inward and during expiration it is moved out or puffing out, it is classical description of a flail chest, and it is possible if there is multiple fractures in the same rib. We have already mentioned this is only possible if you look from the back. So by standing on the back, you can examine the spine, you can look at the different deformities like scoliosis, kyphosis, kyphoscoliosis, gibbous, or other very odd deformities. And when the person is lying down or on sitting posture, you can look at ribs, you can look at any swelling, and when you are standing at the back, you can ask the person to bend forward and you can look at the pulsation in the intercostal space. We call it the Sussman sign. So when a person is bending down, you look tangentially at the intercostal space, and if you see a nice pulsation, which is in a normal person, never visualized, if you can see clearly, this is classical in case of a coarctation of aorta, and we label that as a Sussman sign. And this you will be able to examine if you stand on the back and ask the person to bend down and touch the toe. That is the best position where you can look tangentially in the intercostal space. So try to look at the different. Say this is a emphysema with, you can see a nice kyphosis. And there is also little amount of what we call as a pectus carinatum. This is scoliosis with kyphosis, a very odd deformities. This is again a smooth kyphosis. Pectus excavatum, pectus carinatum. You look at the kyphosis, normal spine. You can look at the scoliosis. This is excessive lumbar lordosis, but lumbar lordosis very rarely produces chest deformity. This is scoliosis. So you try to examine the spine by standing at the back. And when you are standing at the back, look at the shoulder, level of the shoulder. So drooping of the shoulder may be secondary due to what we call as trapezius involvement. That we'll be talking in a CNS. And we have already mentioned, you look at the kyphosis, scoliosis, you can see here a very odd deformities. Very rarely you come across such odd deformities, which are always congenital. So you can look at the spine, you can look at the rib, you can look at the sternum also in sitting posture. Best way, supine posture, you will be able to look the anterior surface of the chest, and in a sitting up posture you will be able to look at the back as well as axilla and even the anterior surface. So kyphoscoliosis you can best make out by standing on the back. You can see kyphosis also little amount of scoliosis. You can see scoliosis in X-ray. So kyphoscoliosis you will be able to make out. You can see a barrel shaped chest with kyphoscoliosis. You can see scoliosis, and along with that if there is an anterior posterior we call kyphoscoliosis. So good number of deformity photographs are here. You can see scoliosis with little amount of kyphosis. This is kyphosis. This is scoliosis with kyphosis. We already mentioned regarding retraction and fullness of intercostal space. It can be because of lung or because of pleural pathology. Because of lung pathology, retraction, fibrosis, collapse of lung, you will have retraction. And fullness because of lung, emphysema, bronchogenic carcinoma. And as far as the pleural pathology is concerned, in pleural pathology, fluid, air, pus, blood, mass. Fluid, hydrothorax, massive pleural effusion. Pus, empyema. Blood, hemothorax. Plus mass, mesothelioma. All will produce fullness. While retraction will be because of fibrosis and thickened pleura. So remember that way, very easy. And air in the pleural cavity, that is pneumothorax, total pneumothorax and tension pneumothorax, will produce fullness. Very frequently asked in your oral. Same thing will be utilizing while position of a trachea. So position of trachea, as we are discussing here, will not be discussing in detail in case of a cardiovascular system. You know that in a normal person the position of trachea is always central. If it is shifted to any one side, whether to the right or whether to the left, we call that as a trail sign or trill sign. If trachea is shifted say to the right side sternomastoid will be little prominent, and that is given a name trail sign or trill sign. This will be because of pull from right side or push from the left side. Say I am giving one example, trachea position to the right side. So if trachea is to the right side, we'll have a right side sternomastoid prominent, and if right side sternomastoid is prominent, we'll say trail sign is positive on right side. And it may be because of pull, because of the right side pathology, or push from left side. Pull will be because of fibrosis, collapse and thickened pleura. Fibrosis, collapse of lung, and fibrosis and thickened pleura because of pleural cavity or pleura. While push from the opposite side, as far as lung is concerned, unilateral emphysema of opposite side, or because of a big mass on opposite lung. Not very common, rare. But by and large the push will be very frequently because of the lung pathology like massive pleural effusion, all massive, massive pleural effusion, hemothorax, empyema, hydropneumothorax, pneumothorax, tension pneumothorax, and occasionally a big mesothelioma or big malignant tumor of the pleural cavity, we call mesothelioma, can push the entire mediastinum to opposite side. So this will be the condition which will change the position of trachea. Now, if you get a big push or big pull, along with shift of trachea, you will have a shift of mediastinum. The shift of mediastinum is because of the massive pull or massive push. But if there is a pathophysiology in apical region, say apical lobes, then you can have only shift of trachea without much shift of mediastinum. Say a simple example. Say if I got a right apical lobe collapse or right apical lobe fibrosis or right apical pleural thickening or fibrosis, I will have a pull and I will have a push if I got say tumor in the apical lobe, which is given a good number of time, Penco's tumor. So this will be condition which will push only trachea without much shift of mediastinum. So you can see here, this side trachea is shifted to this side. So this sternomastoid has become prominent. So we'll say trail sign is positive on this side. So trachea is shifted to left. And along with that, if there is a massive pull from left side or push from right side, you will have what we call as apical impulse shifted to left, or entire mediastinum is shifted to left side. But if there is only apical pathology, then only trachea will be shifted without much shift of mediastinum. So look at the position of trachea. While looking at the position of trachea, we are not supposed to use finger or even palm. So inspection, best way to examine trachea is ask the person to lie down, remove the pillow, so there is an hyperextension, and now put the chin exactly in the center and compare right with left sternomastoid, and you can examine what we call as a trail sign or Trill's sign. I already mentioned all this finding, so I don't have to repeat. These are all what we call as pull. These are push. We have mentioned all those things. We already mentioned all these things, so I'm skipping over. Yes, at your leisure time, you can have a pause and you can go through. Very frequently ask in your oral. Very, very common. Most common thing, ask in your oral. So trachea position with or without shift of mediastinum. Apex beat and pulsation will be discussing more in detail in cardiovascular system. In normal person, apical impulse is on the left side, fourth intercostal space, just inside the mid-clavicular line. But on inspection, we cannot make out. Only in case of a thin-built individual, particularly in a male, you will be able to make out very easily because it will be just below the nipple on the left side. With shift of mediastinum, apical impulse will be shifted to the left if there is a pull from the left and push from the right, or will be shifted towards sternum, that is right side, in case of a push from left or pull from the right. Also, apical impulse will have change in the position without any shift of mediastinum because of right ventricular hypertrophy, or because of left ventricular hypertrophy, or because of biventricular hypertrophy. You should also look for pulsation in other area that is apical impulse, pulmonary area, aortic area, parasternal region, suprasternal notch, infraclavicular region, and posteriorly look for Sussman sign. But all this we'll be discussing in detail in a cardiovascular system. So look at the apical impulse, position of apical impulse we'll be discussing in detail. And then we come to what we call as a respiration and respiratory movement. Almost majority of the thing we have discussed in what we call as vital sign, that is respiratory examination, or what we call as a respiratory rate or respiration. And in that we have discussed regarding rate, type of breathing, rhythm, inspiratory phase, expiratory phase. Now I'll be discussing little bit regarding this portion and little idea regarding inspiration and expiration. So whenever you are looking at the rate and rhythm and type of respiration, along with that you look at the movement, chest movement, and best way to examine the chest movement is by standing at the foot end. So stand at the foot end, compare right with left. In normal person, both sides should move equal and symmetrical. During inspiration, chest expands. During expiration, the chest will go back to the original. Now, if there is asymmetrical expansion, the part which is expanding less is always a disease site. It is absolutely impossible that the site which is expanding more is a disease. So the site which is moving less, say a right side chest movement is diminished, that is a disease site. And the diminished movement indicates either the disease of lung or disease of pleural cavity. Disease in the lung can be fibrosis, collapse, thickened pleura, as well as all the majority of the disease like tuberculosis, pneumonia, interstitial lung disease, fibrosis, collapse, etc. And in a lung, the movement will be restricted in case of a pleural effusion, pneumothorax, hydropneumothorax, hemothorax, empyema, etc. or thickened pleura, all those conditions. And I have already explained to you of flyal chest that the chest will move inside instead of expanding during inspiration, and during expiration it will move out instead of retraction. This is typically described as a flyal chest. And also while looking at the respiratory movement, you can look at what we call as the inspiratory phase and expiratory phase in one respiration. If inspiration is markedly prolonged, it is much longer than expiration. It is very frequently in case of an inspiratory obstruction, very common in case of a laryngeal obstruction, and person will have typical sound we call as a stridor. If expiration is markedly prolonged as compared to inspiration, that is very common in a obstructive lung disease, or we call as a chronic obstructive lung disease. If person is having pursing of the lips, ali nasi are expanding more during respiratory movements or during inspiration and expiration, there is a nasal flare, ali nasi movements, little pursing of the lips, accessory muscle of respiration, that is the sternomastoid is working, person is making much effort, there is wheezing sound which is being audible, there is central cyanosis, and person is uncomfortable, person is not able to speak properly during that respiratory effort, because person cannot make an effort to speak during that respiratory distress. These are all the typical finding in case of a respiratory distress. So all these things you should look during examination of respiration and movements. Yes, some of the things regarding rate, type of respiration and rhythm we have discussed in vital signs, that is temperature, pulse, blood pressure and respiration. So I've discussed in respiration. So go through that at your leisure time. So rate wise, tachypnea, bradypnea, hyperapnea, and breathing pattern wise, hyperventilation, hypoventilation, chain stroke breathing, Byrd's breathing, Kussmaul's breathing, all those I've discussed. I've discussed all this: eupnea, tachypnea, bradypnea, apnea, hyperapnea, chain stroke breathing, Byrd's breathing, Kussmaul's breathing, apneustic breathing, all those things we have already discussed in respiration vital signs. These are all the charts. Very frequently this will be asked to you in your oral. Please go through at your leisure time. And I've discussed in detail in vital data or vital signs respiration. Go through that particular again and again. There are few words which are very frequently asked in your oral regarding apnea or pnea. Dyspnea, you know, whenever the person is complaining of shortness of breath, we call it a dyspnea. Bradypnea means decrease in the respiratory rate less than 8. While tachypnea means increase in the respiratory rate. Tachypnea does not mean dyspnea. Paroxysmal nocturnal dyspnea is a sudden onset of shortness of breath when a person goes to sleep. After certain time, person suddenly becomes breathless. He wakes up, and after a erect posture, after few minutes, he becomes comfortable and he can go back to sleep. That is paroxysmal nocturnal dyspnea. We'll be discussing in detail whenever we come to cardiovascular system. Orthopnea is when the person goes to supine posture. Within few seconds, person becomes markedly breathless and he has to sit up. He cannot continue lying down flat. That is orthopnea. Platypnea means person is more breathless in sitting up posture and he is better in a lying down posture. And there is one condition we call tripopnea. That person is having a shortness of breath in one lateral decubitus position. This is because when the person say lie down on the right side, which is a diseased side, he is more comfortable, and when he lie down on the left side and right side, which is a diseased lung, becomes non-dependent, he becomes more breathless. That is called tripopnea. So count your respiratory rate. Look at the type of respiration, whether it is abdominal or abdominothoracic. All this I have discussed in detail. This is palpation. Sorry, this is not inspection. When you are doing inspection, you are not supposed to touch. So when you are looking at, you are comparing right with left, always stand on the back side of the patient and compare right with left. Movement of chest wall, whether it is asymmetrical, best way is to, if you want to examine the posterior side, sitting posture. But anterior surface, lying down posture, standing at the foot end. And we have already told you, the unilateral diminished, bilateral diminished in emphysema, bilateral hydrothorax, obesity, bronchial asthma, myasthenia gravis, etc. will have a bilateral diminished movement. And in unilateral pleural effusion, unilateral pneumothorax, unilateral hydropneumothorax, consolidation, fibrosis, collapse, thickened pleura, unilateral will have unilateral diminished in respiratory movements. So already we have discussed a lot of these things, and in flail chest it will be opposite movements. There is one thing which can be asked sometime in your oral if you utter this particular word, that in a COPD, remember this properly, in COPD diaphragm is usually flat. So during inspiration, the ribs are pulled little bit inside. So it is an inward pull because of the diaphragm moving little down. Already it is flat. The ribs are already horizontal. So when diaphragm tries to contract, it moves ribs little inward. It pulls little inwards and medial. And that is given a name Hoover's sign. And it is very characteristic in case of emphysema. Once in a while can be asked in your oral, what is Hoover's sign? So do remember. We already mentioned the accessory muscle of respirations are mainly sternocleidomastoid, platysma, pectoralis, serratus anterior and scalenus anterior. But sternomastoid is very, very prominent. So we pick up this. We rarely make out platysma as second muscle, and pectoralis, serratus anterior and scalenus we rarely look for. So whenever a person is using this particular muscle during deep inspiration, those we call as accessory muscle of respiration. So during expiration, you are taking an advantage of abdominal recti muscle and latissimus dorsi. So look at ali nasi, sternocleidomastoid. These are the two commonly we look at. The movement of ali nasi and sternocleidomastoid as an accessory muscle of respiration. So this is sternocleidomastoid, this is ali nasi. This is on palpation. This is not inspection. This is on palpation. I've taken those so you can see what you are looking for. Along with that respiratory muscle movement, if there is a cyanosis, if there is a use of even scalenus anticus muscle, if there is a diaphragm movement in the opposite direction, that is, it is pulled inside, these are all the signs of respiratory distress. We can call as Hoover's sign, as respiratory distress. And if there is a flail chest, during deep inspiration, it will move inside, and during expiration, the part of the chest wall will move outside. That is typical of flail chest. This is blue bloaters, very classical, and this is pink puffers with a pursed lip, very commonly seen in an emphysema. There is something called as a Dale's sign. You will have a nicotine staining here and typical smoker face, very difficult to describe. So whenever you get person is anxious, accessory muscle of respiration is working, clenching is there, cyanosis, gasping for air. If you have got a laryngeal stridor, that is sound during inspiration, there is a clubbing, there is a central cyanosis, ali nasi is working, all these are signs of respiratory distress. Pursed lip, very typical in case of COPD, particularly emphysema. And later on there will be decrease in respiratory rate, increase in tidal volume, and decrease work breathing capacity, which will tell you that the person is deteriorating. You can have certain times a typical noise because of increased effort made during respiration. And some of those signs are very, very peculiar. We call as, what we call that as wheeze, stridor. So those particular, and whenever you are doing auscultation, ask the person to reduce those sound as much as possible. There is something called as a respiratory alternance. Normally both chest and abdomen rises during inspiration, but if paradoxical respiration implies that during inspiration chest expands and abdomen collapses, this is because the muscle is getting now fatigued, and that is being described as respiratory alternance. Look at the nipple. Both nipples should be at the same level. If that is being, this will be very important in a male. So if nipple is retracted, if nipple is shifted, it may be secondary due to chest deformities. And you can look at the skin also, ulcer, any swelling, scars, cold abscess, etc. Dilated veins are very important in superior vena cava and inferior vena cava obstruction. We already mentioned during alimentary system examination. We'll be stressing little bit on a subclavian vein obstruction. In a case of a subclavian vein obstruction over the thorax, close to the shoulder, you will see a dilated veins over the chest. And in case of a superior vena cava obstruction, you will see a dilated vein over chest as well as abdomen, vertical dilated veins, tortuous vein, and blood flow is from above downwards in case of a superior vena cava obstruction. Along with that dilated veins, you will have a dilated veins in the upper limb, edema in upper limb, puffiness of face. JVP will be elevated, non-pulsatile. Very, very important, non-pulsatile. Because of complete superior vena cava obstruction. That will be characteristic of superior vena cava obstruction. In case of an inferior vena cava obstruction, you will have again a parallel dilated veins over the chest and abdomen. On palpation, you can find out the blood flow is from below upwards. You will have a edema of lower limb, ascites, oliguria. This will be in an inferior vena cava. But there will be no puffiness of face, no edema of neck, no edema of in upper limb, and no dilated veins in upper limb. This rules out superior vena cava obstruction. If JVP is normal, it is less likely to be raised central venous pressure. But JVP will be elevated if there is an elevated central venous pressure, either because of congestive heart failure, very common in right ventricular failure, or right ventricular failure following a left ventricular failure, that we call as biventricular failure, or we call congestive heart failure. And JVP will be elevated and non-pulsatile in case of a superior vena cava obstruction. Scar, I am not going into detail. You look at the site size, site length, that is size or length, any keloid formation, any discharge, is there any gapping, is there any scar hernia, and if there is any branding marks. Look for all these things, and depending upon the type of the scar, some disease you can pick up. Nowadays, usually mid-sternal scar. Say this is a mid-sternal scar. I'll show you this. This is a typical mid-sternal scar, or we call mid-sternal split scar. That is the scar very commonly done for CABG, major surgery on a mediastinal structure, major surgery on lung, major surgery on heart, etc. Nowadays, this scar are replaced by a minimal invasive surgery we call as small scar will be seen, which are mainly for endoscopic surgery, or we call minimal invasive surgery. So that has replaced a big scar. A drainage scar can be seen secondary due to drainage done for hemothorax, pneumothorax, or hydropneumothorax. You can have a burn scar over the chest, quite common, and very, very rarely you can see a branding scar for the chest pain, which is done usually in a illiterate people and in a what we call as backward class people. Injury scar may be very common again because of stab wound injury, bullet injury, etc. So look at all those scar and mention in detail regarding the scar. These are some of the scar. This is a drainage scar. You can see this is a drainage scar. This is drainage scar. Then this is a mid-split sternal scar. This is a thoracotomy, thoracoplasty. You can see a big scar. Nowadays, all these type of a scar are gone. You usually don't come across this. This is injury marks following an injury, either maybe because of roadside accident or a blunt injury as a traumatic injury. If you see any swelling, again site, size, shape, surface, impulse on cuffing, pulsation and color, which is very easy on inspection. See, you can see these are multiple swelling. These are all secondary metastasis. This is gynecomastia. This is spider nevi. This is pulsatile swelling, aortic aneurysm. This is again a pulsatile swelling, aortic aneurysm. Try to give in detail. This is more asked on surgical side, but can be asked even on medicine also. Then as far as pigmentation is concerned, spider nevi, we have shown you this. This is classical spider nevi. Then these are small moles, or we call telangiectasia. You can have a black pigmentation very classically in case of Addison's disease. You can have a tinea infection over the chest, we call tinea corporis. You can have a hypopigmented skin patches called vitiligo, and also you can have hypopigmented in case of leprosy, it will be associated with loss of sensation, and occasionally you can come across a post-herpetic pigmentation all along the intercostal space, unilateral, very classical in case of a post-herpetic pigmentation. This is typical spider nevi. You can see this is spider nevi, very frequently seen below the clavicle in a fair person, and it is a characteristic in a case of a cirrhosis of liver. This is herpes zoster, and when it heals, there will be hyperpigmented all along the intercostal space. Occasionally, you can have a pigmentation because of fashion, that is we call tattoo. So that can be also seen over the chest. Yes, some peculiar smell you can identify, we call as a fetor hepaticus in hepatic coma, typical uremic smell in case of uremia, because of a very bad oral hygiene, halitosis. If you have got a severe bad infection in oral cavity, you can have a false smell. Even sometime in a case of a lung abscess, and also which may be because of Staph aureus, you can have a very false smelling. If person has got OP poisoning, you can have a smell of OP. If person is consumed with kerosene, you can have a kerosene smell. And in case of a diabetic ketoacidosis, you can have a fruity smell. These are some of the smells which are easily identifiable, you should look for. So I end my lecture here. Almost I have tried to cover up what you can look in inspection, particularly in a person with a respiratory system involvement, that is we call as inspection of chest or inspection of respiratory system. I have tried to cover up almost majority of the part. I'm sorry if I've forgotten some of the things. By and large, I've tried to cover up. So I thank you all for taking out time. I know that your time is valuable, and I appreciate for spending some of the time with me. If you feel this lecture useful to you and you like this particular lecture, you press button like, subscribe, and you can share with your friends also. So I end my lecture here. We'll see you in next lecture.